Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/ncd. This activity is supported by an educational grant from Calliditas Therapeutics.
Hello, I am Richard Lafayette. I'm a professor of medicine at Stanford University, and I want to welcome you to this presentation. It's my great pleasure to have my close colleague, Professor Jürgen Flörger, joining me. Jürgen, why don't you go ahead and introduce yourself?
Yeah, welcome everybody. I'm from the University of Aachen, which is where the Netherlands, Belgium, and Germany meet. And I'm, like Richard, professor of medicine and have a strong interest in IgA nephropathy.
And today we're going to talk about the evidence for and against the multi-hit hypothesis of IgA nephropathy. We're going to talk a little bit about the role of the gut mucosa in IgA nephropathy and the implications for treatment as per the KDIGO guidelines, and briefly about where and how new classes of medications act within this process. So it should be very exciting. And we can already start, Jürgen, about the pathogenesis of IgA nephropathy and how well established you think this four-hit hypothesis really is, and maybe review the four hits, which of course is that a patient who is genetically predisposed gets an insult to their mucosa, usually the gut mucosa, and respond with an IgA response. But in this case, it's very rich in galactose-deficient IgA, which gets into the systemic circulation, leading to high galactose-deficient IgA levels, which is recognized as an autoantigen. And we get antibodies to that galactose-deficient IgA, which could be IgG or IgM or IgA in nature. And therefore, we have circulating immune complexes, which the kidney can specifically and non-specifically trap when it's filtering the plasma. And so you get circulating immune complexes in the mesangium of the kidney that then can lead to inflammation and injury. So again, hit one, the increased galactose-deficient IgA, hit two, the autoantibodies, hit three, the circulating immune complexes, hit four, deposition in the kidney, and finally activation with inflammation, complement activation, and therefore hematuria, proteinuria, and the risk for progressive injury. Do you think that's our truth right now?
Well, I think it's important to stress that this is still a hypothesis. And in particular, the role of Gd-IgA and of autoantibodies to it are still being discussed. And this is against the background that a group recently reported on mice which overexpressed Gd-IgA1, human Gd-IgA1, in the system, and they develop nothing, not even IgA deposits in the kidney. So that group feels it's more a biomarker. And as to autoantibodies, clinically speaking, IgA nephropathy doesn't behave like a typical autoimmune disease. And you, Richard, yourself led the key trial where rituximab failed. I can't think of too many other autoimmune diseases of the kidney where rituximab doesn't work at all. So all of this is still a hypothesis. It could be that other IgA is depositing in the kidney as well. Don't forget, 8% of the normal population seems to have IgA on autopsy in the kidney. So maybe the kidney and the mesangium have a particular propensity to capture IgA. This is all open for discussion.
Yeah, and we're going to have fun discussing that further because, of course, the reason it is a hypothesis is because in most patients, galactose-deficient IgA is high. When it can be measured, those autoantibodies together with that are in the kidney and tend to correlate, but not perfectly, with degree of injury. And of course, now that we have some treatments that reduce galactose-deficient IgA, they seem to be highly responsive to those treatments, but they may be doing other things. So it is a fun discussion. and we will carry that on a little bit further. For our audience, we do have a challenge question about how confident you feel about understanding the pathogenesis of IgA nephropathy. And before we move on, please answer this challenge question. And Jürgen, I'll turn it back over to you to describe our 2025-2026 KDIGO algorithm looking at therapeutic targets and treatment positioning in IgA nephropathy.
Yeah, so this is the 2025 version with the 26 update, and it gives you an idea on how quickly the field evolves. But what we propose in the guidelines are the two dark blue boxes, and that you should target this in parallel. That is the IgA-specific drivers of nephron loss, which is deposition of IgA, immune complex formation, etc. And then in parallel, target the generic CKD aspect like we would generically treat any CKD, so blood pressure control, CV risk reduction, lifestyle, RAS blocker, dual endothelin angiotensin receptor antagonists, SGLT2 inhibitors, or the latest addition, a pure endothelin receptor antagonist. And on the other side, we have measures that reduce synthesis of pathogenic forms of IgA. And you note that we've been deliberately vague here. And stop the immune complex injury. And this would have been classically steroids. Now we have Nefecon in this targeted release formulation. And now we also have complement inhibitors and B-cell modulators, which we'll go into in more details. And then there are some country-specific measures.
Yeah, and this is a wonderful framework and really shows how in parts of the world, particularly the US and China so far, we have so many choices that we didn't have even 5 years ago, just with our conservative manage of CKD, with the SGLT2 inhibitors, the endothelin blockers, and I think soon the MRAs. So you have to decide exactly how much of that you want to use depending on the patient's risk. And then on the left side, a lot of medications to be more targeted to IgA nephropathy. And in fact, there is that richness in approach where we have, as you said, moving from systemic immunosuppression to more targeted therapy, targeted Nefecon, which is designed to get to that GI-associated lymph tissue and replace systemic steroids and try to reduce B-cell activity in galactose-deficient IgA, has reduced proteinuria, slowed progression, so that's approved for use. The B-cell world to go upstream and really stop galactose-deficient IgA production and autoantibodies. We have 4 distinct programs globally and a 5th one in China alone, looking at blocking either APRIL or APRIL plus BAFF. And as you know, sibeprenlimab is approved in the United States. Atacicept and povetacicept are looking to get approved later this year. And we'll probably hear from zigakibart trying to be approved as well. And then anti-CD38 antibodies have had proof of concept to be anti-proteinuric and GFR stabilizing, but they're just early coming into phase 3 studies. And then turning more downstream at complement inhibition, it's getting very exciting there as well, where iptacopan has completed their phase 3 trial, reducing proteinuria and reducing GFR progression, and awaits full approval, but is approved for use in the United States. And then cefaxacin as a RNA inhibitor to factor B looks promising in phase 2, but we await phase 3 data. Ravulizumab as a C5 inhibitor has shown a robust reduction of proteinuria, and we await further data and regulatory action for that. And we have 2 approved drugs in the United States, sparsentan, the dual endothelin angiotensin II receptor antagonist, and atrasentan, a standalone endothelin receptor antagonist, both effective at reducing proteinuria, both slowing GFR progression. So again, from these, I guess, rags to riches story. We have lots to talk about. And I think going forward, Jürgen, we'll be thinking about how effective are these drugs and classes, and to what extent do their efficacy results support current thinking about IgAN pathogenesis. Any closing thoughts, Jürgen?
We have a lot to discuss.
Yeah, I think we really have moved ahead with the pathophysiology. We have lots of tools. And now, please answer this second challenge question.
In this part of the discussion, we will talk about the right side of this latest KDIGO algorithm, that is managing generic responses to IgA induced nephron loss. And the rationale for that obviously is that by the time that patients make it to our offices, most of them have established and often moderately or quite badly advanced CKD, and they need to know about CKD and how to treat it. I have the luxury of spending half an hour with my patients when I first see them, and this is probably the most important half hour in the lives of my patient, because I explain to them a lot of things. What's a healthy diet, how to restrict sodium, telling them in quite drastic words, if they smoke, they're crazy, telling them about weight management. I see way too many patients being referred to me who come with the question of steroids and they are grossly obese. So I would rather treat the obesity than giving them steroids. And I talk to them about sports, what is good sport, bad sport. Probably weightlifting is not a good idea because of the associated blood pressure peaks. So it's a fairly extensive discussion, but I hope that is really worthwhile for my patients. So the initial treatment approach for most patients under the old paradigm was exactly this. But Rich, what's your experience? How effective is this pure supportive care alone in IgA nephropathy?
I sort of feel if we're lucky enough to get patients relatively early with relatively moderate proteinuria, I've had lots of success with RAS inhibitors alone, getting patients to really low-grade proteinuria, seeing for decades that they have stable kidney function. And I'm really excited that with new tools, with using SGLT2 inhibitors, with using other supportive therapies like endothelin antagonists, that for patients who's really close to goal and have good GFR reserve at the beginning, that supportive care can be a highly effective way at managing patients. But maybe for higher risk patients, we have to use more of a full package. And again, especially those patients who will listen to that important 30 minutes and diet and exercise and stay trim tend to respond even better to that supportive care.
Yeah. And the question obviously is, are we really using supportive care to the maximum extent? I've seen so many patients go to full remission if you really optimize RAS blockers. And this is a look at recent IgA nephropathy trials and looking at just the control arm. There were two types of trials. One on the right, where everybody was required to be on optimized RAS blocker. And on the left, a few trials really mandated that they receive a maximum allowed and recommended dose of an angiotensin receptor blocker. And the remarkable finding is that the left box had an annual GFR loss below 4 mils per minute, whereas the right box, even under trial conditions, had a GFR loss of anywhere from 4 to 15 mils per minute, implying that maybe even under trial conditions, RAS blockers are not used to the absolute full extent. And that, of course, is unacceptable. We need to use these cheap, established, and very safe therapies. So, but in addition to that, and like Richard, I too have patients who go into full remission, but many don't. And for those, we really need to discuss the key paradigm of hit hard and early, risking maybe that we even overtreat some patients. And Rich, what is your feeling about this hit hard and early approach?
Yeah, I think there's certainly a substantial proportion of patients who present already with a lot of GFR loss, who have clear bad changes in their biopsy, heavy proteinuria. And then I welcome that approach to really give them very good supportive care and then not wait a day, but get into an IgA specific therapy, targeted therapy, if you will, because I don't think I want to wait 2, 3 months to see. In those patients, really, they've already lost nephrons. They have very high risk of losing more quickly. So there is a group of patients that I do think you have to hit early, hit harder. And I think that that's now that we have safe targeted therapies, there really shouldn't be hesitation.
Yep. So what do you know about the current treatment guidance for IgA nephropathy? And please do answer this challenge question. So, Rich, let's turn to the big question. How can we identify high-risk individuals which really would benefit from intensive hit hard and early therapy in addition to what we have? And maybe you can go over this for a second.
Yeah, I think we feel we have predictors of a worse prognosis, uncontrolled blood pressure, older age, um, high lipids, those patients who are already obese. Certainly the strongest predictors are proteinuria and kidney function. And we know that the pathology adds to our risk assessment as well, especially if it's fresh. Um, so I do think we have these predictors of patients, and the more out of line each are in combination, the more worried we're going to be about an individual patient. And I think that would lead us to more of a quote combination therapy with using targeted therapy together with starting our more conservative generic CKD therapies.
Yes. And in the guideline, we recommend that you type all this information into the International IgAN prediction tool. You can find it freely on the web, and you see that you enter GFR, blood pressure, proteinuria, age, race, ACE inhibitor, and it heavily relies on the MES-C score. Now comes the big but. The MES-C score and this prediction tool, they were all derived from historical cohorts. And these historical cohorts, sometimes some of them even didn't have a RAS block on board. So the big challenge is to really have a prediction tool and pathology scores that mimic today's populations. And I am looking specifically here at a study that we recently published from Beijing, where they took 677 patients receiving any of these new therapies: endothelin receptor antagonist, hydroxychloroquine, Nefecon, SGLT2, telitacicept, and 190 then experienced the primary outcome of loss of kidney function. And look at the comparison of average predicted risk and the observed event rate. It should be diagonal, the red arrow, but in reality, it was essentially flat, suggesting that we will need to update these prediction tools. And of course, the other big challenge is having prediction tools for much longer periods. So more than the 18-month or 6 years that is covered by the IgAN prediction tool. So in a nutshell, please rethink CKD therapy. Please ask yourself, am I doing everything I can? Can I really optimize these really cheap, easy, safe, established therapies? And that, I think, is the key message of this second learning block. And now, please answer this second challenge question.
Here we're going to come back after having our patients on wonderful supportive therapy and deciding if they simultaneously need to be on more IgA nephropathy targeted therapy to think about those individual therapies. And we've gone through the KDIGO approach that patients at risk of progressive kidney function loss, we should simultaneously at least consider managing that generic response to IgA nephropathy with lifestyle RAS inhibition and now newer therapies such as SGLT2 inhibitors, endothelin blockers, and particularly for those patients at significant risk, simultaneously give them some agents that manage that IgAN specific drive for kidney loss. So we will talk more about what the trials support in that regard. First, we'll review the results for Nefecon, which, as you know, is a targeted agent to the gut mucosa as a B-cell priming agent. And the NefIgArd study was a phase 3 study comparing Nefecon against placebo. And it was effective where after 9 months of therapy, there was a substantial reduction of proteinuria, which intensified at 12 months, but then after an initial 12 months of follow-up, there was some loss of that antiproteinuric effect. And similarly for GFR, over 9 months, there was stabilization of GFR, but after the agent was stopped, the progression rate sort of parallels the placebo group, such at the end of the 2-year study, there was a sustained GFR improvement, but there was progression at a similar rate of placebo at that time point. But the agent was overall well tolerated, and that brings us to other agents. For B-cell agents, using an anti-APRIL drug such as sibeprenlimab was also well tested, and we have data out to 1 year now where there was a very substantial antiproteinuric effect that was well tolerated. And in that 1-year therapy, there also is a very nice GFR preserving effect with a large difference between sibeprenlimab and placebo at that time. And again, the drugs were well tolerated. Jürgen, why don't you take us through findings for complement inhibitor therapy?
Sure. So this is the approach which is kind of opposite. Nefecon and sibeprenlimab will reduce the formation of pathogenic IgA and immune complexes. Iptacopan, a selective inhibitor of factor B, so of the alternative pathway, will limit the inflammation that is sparked by this deposited IgA. And here you see the final eGFR outcome of the iptacopan phase 3 trial, and you can see that iptacopan roughly reduced GFR loss over the 2-year period by half, not quite normalized it, but led to a marked reduction. And the other phase 3 trial, we're now switching back to the generic CKD box, is endothelin antagonism, and this is sparsentan, the dual endothelin angiotensin receptor antagonist, and you can see that there's about 1 ml difference in annual GFR loss with sparsentan. So back to you, Rich, for the next one.
Yeah, and so likewise with dual endothelin antagonists, standalone endothelin antagonists were also effective at being well tolerated, at reducing proteinuria, and in the GFR data, similarly at 2 years follow-up, slightly longer than 2 years, there was still that preservation of about 1 ml per minute compared to just background standard therapy with RAS inhibitor and in some cases RAS plus SGLT2 inhibitors. So we have numerous therapies that are available. Please answer this challenge question. And thus we're left with this new era where we have numerous agents that can treat IgA nephropathy, that reduce proteinuria, that slow GFR progression loss, and that's a wonderful advance. But I think we have some lessons we haven't learned yet. And Jürgen, what do you think about choosing among these agents? And I know they haven't all come to Europe yet, but you're anticipating that several will. how are we going to choose between these agents?
Well, right now, let's say the fundamental insight is they all work in this trial population. And the other fundamental surprising insight is they seem to work in everybody. All the subgroup analysis very consistently shows that everything seems to work in everybody, at least of the trial population. No mention of patients not entering trials. So it'll be really hard to tell what is going to be the best treatment in the future. My most personal exciting is in the field of B-cell modulation, because there we're coming close to causal therapy. Obviously, if you have no IgA, you will not progress IgA nephropathy or have no IgA nephropathy. But we'll have to see whether combination therapy, let's say, of a complement inhibitor with a B-cell modulator will do the job. And of course, sparsentan is a different, and atrasentan is a different discussion, because that's generic CKD therapy.
Yeah, I think those are all excellent points. And, a lot of these agents are new. We're going to have to learn about their longer term safety because some of them haven't been even used in other diseases and have only been used for 1 and eventually 2 years. Some of these drugs are very, very expensive so far in the United States. So we have to think about cost effectiveness as well. I think in our first session, we talked about risk evaluation. And again, some of that cost effectiveness will probably depend on that as well. And then, as you mentioned, maybe as further efficacy data come, we may be able to prioritize some drugs also based on efficacy, with the B-cell agents at the moment looking like maybe they're the best able to truly stabilize kidney function, where for the others, they may need to be used in combination to really get slow progression. So I think we're going to learn more. And of course, talking to our patients is incredibly important, because some will prefer IV infusions, some will prefer shots frequently, others infrequently, and many will prefer those agents that are available just as tablets, or capsules. So I think we're going to learn more as we get longer term data, and it's going to be very, very valuable. But again, it's just so wonderful to have these options. Again, another issue is that for some of our agents, they've been designed to be given short term. And what we've seen so far is that for many of them, the pathophysiology rapidly returns. For targeted steroids, we do see a resumption of proteinuria and GFR progression soon after they're discontinued. For complement blockers, we do see that off drug, there is a risk for their proteinuria to return after several months and then get controlled again back on the agents. And for the B-cell agents, we've also seen, that off drug, the pathophysiology returns. So there may be a need to treat more long term. Jürgen, any comment about that quickly?
No, it's it's not to be expected that these B-cell modulators or complement inhibitor or steroid will stop and eradicate the disease. That is the biggest challenge, that we have to get outside of clinical trials, which usually last maximum of 2 years, and really look at 10, 20 years. And we simply have no idea whether these treatments will do the job for that long a time.
Correct. And for now, it's just wonderful to have lots of agents that we know are effective, well tolerated, and we need to choose them, and we will learn how to best use them in isolation or in combination soon. And now, please answer this final challenge question. Thank you, Jürgen. Thank you, audience, for watching. Much appreciated.
This has been an activity published by Peer Voice.